Hello, dear viewers. My name is Susanna Zsoter. I am a patient expert in oncology for gastrointestinal tumors, and I am pleased that today I can join Professor Lordick as a patient representative for the ESMO report on gastrointestinal tumors. Professor Lordick has brought many exciting studies for us today, and I hand over to him.
Thank you very much, dear Mrs. Zsoter. My name is Florian Lordick. As just mentioned, I am working at the University Cancer Center Leipzig. I am head of the oncology department there and have been involved for many years with tumors of the digestive tract, the gastrointestinal tumors. To be honest, I have not brought that many studies, although there were quite a lot at the ESMO, which took place just a few weeks ago, and I have 3 studies on colon cancer for you and rectal cancer, all 3 of which I consider very worthy of discussion. Now I will show you potential conflicts of interest. Those are companies that either support research or with which I am involved in training or as a consultant. We are now talking about colon cancer and rectal cancer, and I will first of all show you a study on a form of colon cancer which is operable typically in the so-called stages 2 or 3. These are both stages in which, indeed, in most cases, an operation is performed first, and then, depending on which risk constellation is identified during the detailed analysis of this surgical specimen and what is shown under the microscope with the lymph nodes, a decision must then be made whether chemotherapy is conducted or not. In many of these stages, a chemotherapy is often conducted, often for 3 months, sometimes for 6, if special. Risk characteristics are present. Now, we know that some of these colon cancers, approximately 15%, show a so-called PIK3CA mutation, which is a mutation in a gene that every one of us has, but that can be altered. Through this alteration, which we call a mutation, this specific gene leads to a particular gene product, the PIK3CA enzyme, which is then subsequently activated and which then contributes to cancer cells behaving even more aggressively, growing uncontrollably, and more easily can spread. Behind this study, SAKK 413 is the Swiss Group for Clinical Cancer Research. They have initiated and also started a study with patients in stage 2 or 3 whose tumors exhibit an activating PIK3CA mutation. That is not a big study that recruited 112 patients. Then came, unfortunately, one must say, this is also officially known among experts, the SAKK faced major financial issues and was not able to bring this study to an end, which is really unfortunate, has now since recovered the SAKK, but the study could not be reopened now, so it is not a large study with 112 patients, but already a very interesting study. All the patients were operated on and then received either a placebo or aspirin for 3 years. Everyone is familiar with that. It is a commonly used medication, and it was examined whether aspirin in this group led to improve disease-free survival, overall survival. There are certain biological factors, backgrounds on why aspirin might work well with the PIK3CA mutation. It involves COX-2 inhibition and corresponding reduction of growth stimulations. But now I don't want to explain the biochemistry. But aspirin, as was already known, like other anti-inflammatory drugs, can definitely have a positive impact. Aspirin not in the dosage that many people usually taken as a headache tablet. That would be 500 milligrams. But there it was, the mini aspirin, or as the English sometimes call it, baby aspirin, taken with 100 milligram. This is a dosage that is also used, for example, in cardiovascular diseases, sometimes taken to permanently prevent blood clot formation. So this is usually a very well tolerated dosage, which people generally do not notice at all. And now, see what, however, in this limited patient group, there were 38 in placebo group, 74 in the aspirin group. This was not a 1-to-1 distribution, but rather a 1-to-2 distribution by random assignment. What effects are showing there? There, the red group is already showing. This is the aspirin group. They have a more extended and improved, better disease-free survival. So, unfortunately, because the patient group is small, this p-value, the statistical value, as you can see, is not significant. So the number of patients examined here is probably not sufficient to really make a completely reliable statement here, where we know how high it is, the probability of error. But still, the curves slightly diverge. Then there is the relapse-free survival, which is somewhat similar to disease-free survival. This includes only deaths that occur due to completely different causes, such as accidents. You can also see that there is a wide variation with a so-called hazard range of 0.49. So in essence, almost a halving of the risk of experiencing such a relapse. The p-value is indeed almost significantly positive here, and we also see, but perhaps the observation period is still too short for that, also possible effects on overall survival, since it seems here that the red curve continues to run higher, while the blue curve eventually drops off, and yet possibly more patients may certainly die. So these are indeed very intriguing data, and they are unique worldwide so far. There is no other study that does the same. There are several studies that have investigated aspirin after surgeries, but not so with this focus on the small group of patients who also have a PIK3CA mutation. And now I found myself really struggling at that particular moment to accurately present the correct conclusion, because we also discussed this controversially at the ESMO Congress. Whenever these studies, when newly introduced, there is also a specialist discussant, that is, someone very recognized from the field. In this case, it was Professor Sebastian Stinsing from Charité in Berlin who discussed it. And he said, well, the study is too small. It doesn't have statistical significance. This is not a standard, what we have seen here. It is an interesting signal. And then we experience something that we don't experience very often. Then a speaker from Switzerland, Uli Göller, defended himself and said he cannot do it like that, except these are effects that can be clearly seen in the curves. The therapy is cheap. The therapy is generally well tolerated. He indeed cannot resign himself with the conclusion that these results are not considered at all. And I am also very curious about the further discussion in the coming months. Guidelines also need to address such data. The fact is, in routine cases, the PIK3CA mutation is not determined. We do not know the status. However, it can be determined. It is a genetic test that costs approximately €250, so it is expensive, but also not the entire world. And taking 100 milligrams of aspirin per day for 3 years is also not really something that is complicated. So I have to say, from my point of view, it is an option. We will also discuss this in our clinic, whether we should talk about it with patients, that we at least offer it. I cannot make any statement about whether then a service that we can only offer if someone is willing to pay for it. But I find that such results need to be discussed. A simple, possibly very well-effective therapy. The study was not conducted just anywhere. It was conducted by very reliable, very serious colleagues in Switzerland. The people, those who develop colon cancer, they are very similar to us, so I can't quite ignore and find them very interesting. I am actually really excited about it now, Miss Zsoter. What do you say to something like this, and how do you believe patients would handle it now? If I were to say in the consultation now, so for you the standard is that 3 months of chemotherapy. We can now also consider whether to conduct a genetic test. There is data for that. They provide indications, but they are not entirely certain.
That's absolutely super exciting indeed, what you just said. Just to make sure I comprehended it correctly. The reason why the results are not conclusive is because the study could not be completed and unfortunately simply has a small number of patients.
Yes, well, if the study had 500 patients instead of 112 and showed the same effect size, if we see what we are seeing now with the 112, then it would be a global success. Then it would be a significantly positive study, and every guideline in the world would say that it must be done starting tomorrow.
Yes, that's exactly what I just thought too. We would pop the corks and would be totally happy. This is, of course, for a certain group of patients. It's a total shame because I believe each of us knows aspirin. It is a very proven remedy. I strongly believe that the level of fear is considerably and significantly lower than it currently is now before undergoing chemotherapy, that one might also do preventively. Personally, I think that it actually cannot be discussed away. This is an option that, with a patient, indeed needs to be discussed. This possibility must at least be considered within a solution space. Whether one decides to do so or not, that's a different matter altogether. But I definitely believe that this is something the group should know and also be allowed to discuss.
It is absolutely exciting what you are saying. I find that indeed very interesting. As simple as your perspective on it is, I feel the same way. It's hard to conceal it, that such data exists.
I can, of course, fully understand that highly esteemed colleagues say the sample size is simply too small. Therefore, that's indeed a beautiful result, but it's not something we can derive and can take a guideline with you. I can understand that just as well. You never know what would have happened in a larger patient group, but these are numbers. One cannot simply dismiss them.
To emphasize it once again, the problem with small sample sizes is that there is a high probability of error. It might be that what the Swiss colleagues have observed here is not a real effect, but a random distribution, and that in a larger patient group or an independent cohort of a second study would be different. I think that is very important to say this once again here. There are effects we see here that can be true, but they can also be wrong. There is simply a high probability of error.
Is there currently a plan for further research, or is it still an open question?
I have a great concern, Miss Zsoter, that it will not take place. Because, of course, now behind a medication like aspirin no longer has a large pharmaceutical company that pushes it, because it could also be used to develop a product that sells well and effectively. Therefore, I fear that this data permanently, or at least will stand on their own for a very long time, and perhaps other progress too, will come with other or similar mechanisms. I fear we will with the having to deal with uncertainty for a long time. That's a shame, and that is a shame. I could imagine if I had such a tumor that I would know my PIK3CA status, at least would like to know, so I can decide whether to embrace the uncertainty, take a mini aspirin for 3 years or not. But it might really be a personal decision. We won't be able to completely solve it now either, Mrs. Zsoter. But I was interested in how you feel about it.
Yes, unfortunately. But I really believe this cannot be dismissed. The option must remain on the table.
Then I would now move on to another incredibly interesting study. This refers to rectal cancer, also known as rectal carcinoma or colorectal cancer. So the last section before the final outlet, the last approximately 12 to 15 centimeters, depending on the definition. I do not want to explain the entire treatment strategy for rectal cancer at this moment, which has indeed become quite complex by now, but I would like to focus on one study now, the OPERA study, which involves patients with not yet fully advanced, potentially by surgery removable, rectal cancer. Here we have seen a development over the last few years that we increasingly discuss with patients whether surgery is needed at all, or whether the combination from radiation and chemotherapy can work so well that the tumor disappears, and that one can simply follow up. So an organ-preserving comprehensive radiation chemotherapy treatment approach. And here in the OPERA study, it was indeed examined in patients who are not so far advanced, who, for example, would not lose the sphincter, where one could actually say the surgery has good chances of recovery. And then perhaps one might need to undergo chemotherapy afterwards if risk factors are identified. And what has been done here, patients who are interested in such non-surgical therapy, like that is indeed a decision, I want to be rid of the organ where this cancer originated, or do I go along with it and say, well, I would like to keep the organ if only the cancer would disappear? I think that this is already quite not an easy decision for each individual when confronted with it, a very challenging situation. But these 141 patients had somehow already prepared their decision and had said, if what is offered to me here works well, I would like to try to keep the organ so as not to undergo surgery. And these patients all received radiation and chemotherapy according to the standards, which is 45 gray, and a tablet called capecitabine, which further increases radiosensitivity. And that was either the usual procedure, which is also listed here as the control group, or additionally a radiation therapy procedure that was specifically introduced through the anus with such a tube to approach the tumor directly and to add further doses there. We also call this brachytherapy, with the radiation source very close to the tumor. And the end point of this very interesting study is organ preservation after 3 years. So how many of the patients did not need surgery? Here you can see the options once more. 2 different radiation therapy approaches, all a combination of radiation and chemotherapy. That was just it for option 1. In option 2, specifically this radiation source introduced near the tumor through the anus, which delivers even more radiation directly to the site of interest. And now to the essential endpoint of this study. You can see there those Kaplan-Meier curves diverge significantly. And what do they show? Indeed, they show the rate of organ preservation. So these are not survival curves, but rather organ preservation curves. And the blue one is the usual therapy. After 3 years, 59% were able to retain their organs. The red curve represents the new therapy with the introduction of the radiation source, In that particular case, 81% of the patients were able to keep the organ. The disadvantage that emerged here is that when the radiation source was introduced, and also in the years thereafter, because a high radiation dose was applied there, frequent bleeding occurred in the rectum. So it is not without side effects. This might make the decision overall a bit more difficult. If I keep the organ, will it still work the way I would like it to? And here are also the results after 5 years. The study now has a longer follow-up. It shows that this effect has essentially been preserved. After 3 years, it was 81%. After 5 years, 79%. With the more complex procedure and 56% in the control group. I find the numbers absolutely incredibly interesting, and you can see that introducing the radiation source brings significantly more benefits. There are now many centers that are really starting to engage with it and to learn it, so that they can effectively offer it to patients to the best of their ability. The specific type of body proximal radiation therapy thus increases the probability of preserving of the colon, of the rectum, and even after 5 years the effect persists. The patients must, of course, as clearly stated in the conclusion, be closely monitored throughout the entire time. There has to be every 3 months, every 6 months, appropriate checks that should be carried out. What does it mean for everyday clinical practice? Actually, quite a lot. The conversations we have with patients are becoming more complex. We also need to inform about all these options. We need to have a very, very precise analysis of the tumor spread, also with a high-quality endoscopy with an advanced MRI, because we simply need to know exactly how the tumor is spreading before we offer such options. There are alternatives to that, which is a very important point. This can only be controlled qualitatively in a certified colorectal cancer center. Otherwise, also in this case, the possibilities for errors with all the negative impacts for the patient are, from my point of view, simply too high. It must be discussed intensively with the patients, the possible advantages and disadvantages of organ preservation with the follow-ups, which are then required also with the possible side effects that the intestine may remain inflamed in the long term or may occasionally bleed again. This is the opera study, Ms. Zsoter.
Thank you very much. That is really very interesting. Just for my understanding, does that mean if we perform organ-preserving surgery, this also means that the probability that one later receives an artificial bowel outlet is then also significantly lower, for example? This would be one of the advantages of working in an organ-preserving manner.
Exactly. No surgery is performed at all in organ preservation. It is important that you ask it again. In that case, the intestine really stays as it is and only needs to be examined. There are now indeed also results, and there are also patients where the tumor starts growing again. These are the ones that are, so to speak, on the unfavorable side of the curve, who could not retain the organ where a surgery still needs to be performed. But by now one can actually say quite confidently that this operation can be performed safely and well, so the option is not lost and does not necessarily have to then take place without preserving the anus. It can be a surgery with completely normal continuity preservation, where the healthy intestine is reconnected to the anus or the last few centimeters, so patients do not necessarily lose the option of surgery at all.
I also find that indeed very relevant. I actually imagine it, just as you have explained it, also quite uncomfortable, the treatment itself. But the curve has also clearly shown that this is indeed an undeniably significant benefit and advantage, or benefit for the group of patients, which requires additional careful consideration. Now, of course, the side effects cannot be completely ignored, and also quite unpleasant indeed, and you really have to manage to cope with the intestinal bleeding for 2 years first, and maintain a good quality of life and have to endure that. Well, to be honest, I think it's not actually something you would say, in my opinion. Okay, that's just the right way for anyone who wants it that way. But it is indeed an intensive discussion that one must carefully weigh for oneself. But if someone says, okay, it is indeed particularly important to me that the numbers are good and that I have a significantly longer, then that is, of course, also something like that must be taken into account. There are many people who would gladly accept that, but it needs to be discussed and thought through carefully, in my opinion.
It's interesting how you put that. We have been having these conversations for a long time now, and also in detail trying to inform patients as well as possible what to expect. We do that. I am an internist, and of course the surgeons do that too. The gastroenterologists do that too. I believe patients need to be very thoroughly informed what this means for each of them, and I also see different decisions based on the final outcome. I see patients who say, I am really interested in organ preservation. I want to go down this path. The disadvantages have now been well explained, but I want him to go and avoid the surgery. And we also actually see patients who say, you know what? The operation is something that I will have overcome in just a few weeks. And then at least I'm rid of this risk organ and does not need to undergo an examination every quarter where I have the fears again. Has it grown back now? Or is there something else coming my way? I really see both decisions. And these must be well-informed decisions, and patients must also feel comfortable with the path.
This again shows how very much important it is indeed, firstly, to go to a certified and very, very good and highly experienced and reputable center, and not just anywhere because it's the nearest. It is often worthwhile with such individual topics as well, to accept travel time and go to a good facility, which also has many cases and very experienced practitioners. And secondly, the collaboration between doctor and patient. This is certainly the decisive criterion for a good treatment success, and a good therapy decision as well.
Fortunately, the information about who is certified and who is not, it is now easily ascertainable. In the tables, you can see exactly for your region which centers have which specialization. Are you a certified oncological center? Are you a certified colorectal center? That just makes the choice a bit easier. And of course, one can also ask around. I also believe that you, with your organizations, you certainly also at least be able to provide advice on which criteria one should focus.
With pleasure.
Then I would now like to show you the last study I have selected, which is also very, very interesting. We have seen them here before and also discussed them. There are now longer observation data, and they are important once again. It specifically concerns patients with locally advanced colon cancer, which is theoretically operable, but you will see it shortly. In most patients who were usually included, really large tumors that were only noticed relatively late, but not yet with distant metastases, and they have a specific genetic characteristic, namely deficient mismatch repair or microsatellite instability. Some in the colorectal cancer sector who know what is meant by it. Hereditary colon cancer diseases are also included, where the genetic defect is located in the mismatch repair genes. There can also be non-hereditary forms involved, where these defects have occurred randomly. And the extraordinary thing is that indeed patients in this group, microsatellite instability or deficient mismatch repair, terrible terms that respond particularly well to immunotherapies. We have many of those now. Ipilimumab and nivolumab are two immunotherapy agents, which can be well combined with each other, CTLA-4 and PD-1 inhibitor. Now, NICHE-2, this is a study that colleagues in the Netherlands conducted, who have a high reputation and are truly recognized by everyone, are very recognized for good reasons and receive awards for it. They have these patients with microsatellite instability or deficient mismatch repair deficient tumors that is almost synonymous and locally advanced colon cancer, included in the NICHE-2 study, and have them here offered immunotherapy initially instead of immediate surgery. That's how it looked like. A total of 111 patients. Seems like a small amount for a common disease like colon cancer. One must know, however, that even here the number of those in which this genetic defect is present is not so high. That might be, roughly speaking, depending on which age group one is dealing with, approximately around 10%. The patients then received a first cycle of comprehensive medical treatment with both immunotherapy drugs, a second cycle with only one of the two immunotherapy agents, and then underwent surgery. The treatment duration here from inclusion in the study until the operation was 6 weeks. So 6 weeks of immunotherapy, no longer. Now let's see what the final outcome is. We have already seen that an incredible number of patients who were operated on, that there was no tumor at all. So not longer detectable, or a very good response was detectable after 6 weeks of immunotherapy. These are things we have seen before. I will skip that. I show here again that most patients have indeed truly advanced tumors. We have a classification according to the T category. The higher the T number, the larger and more invasive the tumor is. This T4 category ultimately indicates that the tumor has already extended beyond the colon, has grown completely through the wall, or even grows into the neighboring organs. Many were from the group and many were clinically recognizable, already definitely positive in large lymph node spread. So a cohort with far advanced tumors, such as 58% women, average age 60 years. That might also be interesting to know. This is what we have seen for the first time. The study had a primary endpoint: how many of these patients do not have a relapse and live for another 3 years after being included in the study. And what the curve indeed shows here is that according to the current analysis, all patients have remained relapse-free and have successfully and safely survived this procedure. For us oncologists, something like that is spectacular. It's really hard to imagine, indeed, that such results are achieved in a disease which is already aggressive. Colon cancer is a dangerous disease. And these were patients with advanced tumors. So under previously common circumstances, like under normal conditions, many patients have already experienced a relapse, and many patients have also died. So this result is truly something absolutely new and undoubtedly spectacular. Then they measured something new as well, namely circulating tumor DNA components. I'm not mentioning because otherwise it gets a bit complicated, through each of these bars. But they took a blood sample at the time of inclusion, what circulates in the blood from the tumor DNA, and then again after the chemotherapy, directly before surgery, after surgery. And what can be seen is that the proportion of patients, the number of cases where circulating tumor DNA became undetectable was increasing. So you can see not only that the patients have survived well, but also how it develops, that the tumor ceases its activity. You can literally observe it here with the ever-growing green bar. How the tumor gives up under this immunotherapy is indeed handled by the immune system, the body's own immune system. It is extremely exciting. So we have learned that ipilimumab, nivolumab, not only leads to a good response, but that such a patient group also, a truly previously unrepresented, never before seen, can potentially achieve disease-free survival, means for everyday treatment indeed, especially for the patients who have these really advanced tumors where even surgery might not have very good chances to lead to a cure, or the surgery would have to be very extensive. If it is noticed that perhaps neighboring organs might also need to be operated on, it then indeed becomes quite challenging to achieve a good result, to say the least. And also more dangerous for the patient, that for these patients, in my view, there is absolutely no way around it, that this genetic feature is measured and that the best available immunotherapy first simply precedes the operation. We also discussed this controversially at the ESMO, whether this should now be applied to all tumors, including smaller, easily operable ones. We are still uncertain about that. The data might not support it yet. If it is a really well-operable, smaller colon cancer, direct surgery is most likely still recommended in many situations. But where the tumors move into a certain critical size range, all of us see this as an incredibly good new option, which is something we all truly believe in, that we want to offer to our patients. Well, that's it actually, Ms. Zsoter.
Thank you very much. This is truly great. I am in particular excited about checkpoint inhibitors and immunotherapies that we really have available now. It is indeed absolutely a revolution for patients. In the past, a few years ago, the available options for treatment would have looked considerably different. I personally also find it really nice to see that surgery no longer has to be so aggressive and invasive when this genetic defect is present, and that there are possibilities to significantly reduce the tumor beforehand, because it really brings a great benefit for those affected. It is, of course, very unfortunate, and I think you also rightly mentioned that they are essentially the unicorns among colorectal cancers, because there are always such great results, which indeed, unfortunately, only apply to a rather small group of patients. But I think it still truly gives an incredible amount of courage to see what we can actually achieve with this knowledge, and what will hopefully indeed also be possible in the future for other molecular genetic causes. So for me, this is truly a great ray of hope for those affected.
I'm grateful to you, Ms. Zsoter, for emphasizing that once again, that this certainly does not apply to every patient. It is indeed important to say that you are absolutely right. And yet I am left with a lot of positives, because when I look back over the past few years, but have discovered so many, including smaller groups, for which there are more solutions now than at the time when I started in oncology in the 1990s and 2000s. At that time, we did not know these groups at all. And when I see how so many more groups can now even be treated better than was the case in the past, then it does make a difference for a large number of people affected by cancer overall. And it tremendously stimulates me to continue engaging in research and clinical research to simply keep climbing, let's say, the next hill or even the next mountain.
That is really very nice. Thank you very, very much.
Yes, I hope you found the selection helpful. There would be much more of interest, but I have great hope that we will also at the next congresses. We'll sit together again with similarly interesting data, and in the end, a beautiful information library is created where patients can look into and gain insights.
I completely agree with you, and I am looking forward to it. Thank you very much, and see you next time.